We're at it again. We've got 5 brief studies on the docket today, so quicker video. I know many people are probably going to be excited about that, so let's not waste any time and jump right in. We're going to start off with, does resistance training improve pain intensity, quality of life, and disability in people with chronic, non-specific low back pain? I like this one. It's a systematic review, so it's really looking back at a bunch of different studies to get a big picture, and it's a high-level quality of evidence. And you can probably already guess what we found, and that is it does. If we look at the 10 randomized controlled trials that it included, it showed significant improvements in pain intensity, quality of life, and disability favoring resistance training. Um, this one even says that the certainty of evidence was rated as moderate. So in a lot of studies, you'll find that they'll break them down into high bias, low bias, low evidence, strong evidence. This one has a lot backing it, saying, hey, the certainty is actually at least moderate. We have systematic review showing that resistance training. So actually, I'll just jump to the conclusion because it says it. Resistance training programs effectively reduce pain intensity and disability in patients with non-specific chronic low back pain. And the moderate certainty of evidence suggests that resistance training can be recommended as a general intervention for non-specific chronic low back pain. It's something we see in the office. It's something we were trained on in school. It's something we see in continuing ed courses. It's something that pops up all over the place in various research articles that we see. So this one isn't telling us anything new, but it is summarizing it because it is a systematic review with pretty good evidence to back it up that, you know what, if you've got back pain that there's no real rhyme or reason or major thing on why it's there, like, my back's been hurting for a couple of months, maybe even a couple of years, anything in there. And there's nothing like surgical, like, don't get me wrong, I'd exercise anybody with any of the conditions that I'm actually about to list. But as a carte blanche, like, I don't have to examine you. I can just tell you exactly what to do. It's like, hey, you have, random low back pain that you've had for years. There's nothing major to it. There's no red flags. Go find somebody to do a resistance training program, or go do one on your own. Like, if you want to get better, this is one of the best things that we can recommend for you. And if you happen to have other conditions where you kind of want to put on the brakes a little bit, it's like, hey, I have surgical hardware. Hey, I have disc protrusions and herniations. Hey, I have, tissues that aren't exactly happy when I do this. Well, my recommendation is going to be the same. You're still going to need to find somebody that's going to be comfortable working you into a resistance training program. It just comes down to the how and how fast, and maybe taking just a little bit more precision in the approach to it. But the treatment is more or less going to be looking the same. The principles are going to be the same. It's just a matter of how gung-ho you can go right off the bat, but nobody should really be avoiding this unless you have acute rhabdomyolysis, where, yes, you went too hard, too fast, too soon, and now your body's actually breaking tissue down. But that's a different tale for another time. Let's move on to the next study. Optimal modality and dose of exercise for relieving pain in patients with knee or hip osteoarthritis. What does this one really say? This one is saying, when they looked at it, what is a good dose, or how much can we do to affect knee or hip osteoarthritis? So what did they actually go through? First up, 92 randomized controlled trials involving 6,000 patients were analyzed, and they found that aerobic training was found to have the highest likelihood in effectiveness. They looked at different things. They looked at strength combined training, flexibility. They looked at yoga. They looked at strength and isolation. And they really tried to tighter it down as to what was the most effective overall. And they ranked them in the conclusion here. So in the conclusion, and then I'll kind of give my 2 cents, exercise effectively reduces pain in patients with knee or hip osteoarthritis. Although no exercise type was found to be superior to another based on probabilistic ranking, so again, based on just generic statistics in this review, aerobic training, strength combined with flexibility training, yoga and strength training had the highest likelihood of being the most effective interventions overall. It identified the optimal dose for maximizing pain relief. That's key. Pain relief was 620 metabolic equivalent of task minutes per week, or METs. It's a unit that some people in the fitness world or strength and conditioning world use to kind of figure out how much it's almost like a dose of a medicine, like how much somebody's doing throughout a week. And they tried to, I don't want to say dumb it down, but make people understand, like, what does that mean, met minutes? For example, that's equivalent to approximately 2 hours of moderate intensity water aerobics per week. And then they said the minimum dose to achieve some benefit in this review was 180 met minutes. So there's a couple things that I want to point out. Two or three things. First up, I appreciate this study because a lot of the times when we develop these conditions, movements can be painful. So one of the things that people tend to do is avoid physical activity when they have these conditions, when in reality, we just have to embrace the fact that, yeah, great, you have hip or knee osteoarthritis. I know that there's going to be times it's not going to be great. In fact, it's probably going to suck. But in the long run, we do need you to get moving so that your body can actually help itself. If you just say, I'm going to avoid all activities that aggravate these things, you're actually going to be worse off because you're going to have muscle wasting, you're not going to have bone building, and frankly, you're going to, for lack of a better word, deteriorate so much faster than somebody who's trying to maintain a minimum quality of life and a minimum physicality. So first up, I like it because this is a way that we can approach talking about a potentially uncomfortable topic with patients, because nobody really likes to think about, oh, I'm going to have to maybe embrace a little bit of discomfort to get through this and make myself better. Yeah, if I phrase it like that, that's no big deal. But sit on the other end of the table, being the one in this pain, hearing that as far as a prescription, like, you wait, you want me to get, in their mind, you want me to hurt myself? That's what they hear. So having studies that help us bridge that gap with communication is huge, by being able to show them these things. The second big thing that stands out to me is they looked at the met minute equivalents for pain relief. While there is overlap as far as other physiological benefits, I want to talk about one thing that you might see in the bottom part of the screen. It's hard to titer out on, because I think this is probably extra small on your screen looking at this second time. But what they have in this chart really is what's called a U-shaped dose-response relationship. And this is very common with almost anything in the exercise world. There's usually some sort of a bell or U-shaped curve when it comes to a dose-response issue. What typically happens? Typically on either end of that U, so at the beginning of the chart and the end of the chart, you have your two ends of the extreme, and those typically will have the same negative results associated with either too little or too much of the dosed activity. Put another way, if you don't do enough of the exercise, you're not going to get the benefit. You're not going to get improvement. You're going to be the same as when you started, or worse, because your body's not adapting to enough exercise. On the other end of the chart, you're doing so much that your body can't actually repair itself in between sessions. So you're actually overtraining and overdoing things for your body at that point in time. So most things kind of have a sweet spot in the middle, where you want to be in the middle part, because now you're getting enough exercise to adapt, but not too much that you can't recover from, so you can keep doing it over and over and get the compounding benefits of being consistent with the exercise. So when they talk about those met minutes on that U curve, they're looking only at pain relief. I think that, considering personal clinical experience paired with general demographics of a standard USA patient in my office, or frankly anywhere in the country, I think we have to encourage our patients to be on the upper end of the U, training or getting closer. Like it is more efficacious to tell our patients to have a higher baseline minimum to get out of pain, as well as other physiological benefits, because the risk of overtraining for a lot of patients outside of a research environment where they have to go because they basically signed a contract and researchers need to see stuff, The risk of somebody actually overtraining is very minimal. In Gen Pop, it's almost unheard of. It's something that we really only deal with under two specific conditions. It's usually going to be high-level athletes are one of the few people that I think of when I think of somebody actually overtraining. And then there's specific condition-based parameters that I would adjust dosage more judiciously. I'm thinking of like your chronic debilitating conditions, some things that you have to manage versus cure, like fibromyalgia. It can be a very thin line between just enough and too much on their ability to exercise enough to get the benefits of this, but not too much that their body, rebounds into significant pain. But going back to my original point, this graph shows a U-response relationship for pain. If that's our only goal, sure, we can shoot for that 620 minutes or 2 hours of aerobic, water aerobics per week. But when you break that down, that's really what, 25 minutes a day, 5 days a week, give or take. That is not uh, enough total time to get additional benefits for other chronic conditions suffered by the masses. So for a patient that would come into my office, if they have osteoarthritis, we would have this talk like, hey, if it's just pain, that's all you need to do is 25 minutes a day. But I would still encourage you to get closer to the minimum recommended effective dose, which again, depending on intensity level, is anywhere from like 60 to 80 minutes a week up to 300 plus. And again, those are minimums and ranges that have been found to help reduce all-cause mortalities, other conditions overall, et cetera, et cetera, et cetera. So I look at this U chart really as maybe this is just the exercise specific, because they only did a handful of exercises in each one of these individual studies, and they amalgamated all of these studies across dose response relationships. From a fancy term, in an isolated environment, they found that there was a chance of overtraining certain exercises that had a diminishing return as far as how often you did it and if it actually had pain dose responses. For somebody with these conditions in my office, I'm still going to shoot for a higher level of standard or a higher minimum standard of physical movement and exercise per week to get additional benefits while making sure that we're managing the pain appropriately. So maybe we just change what exercises, maybe we change certain intensity levels, but I want to find somebody and push somebody to be on the far end of the chart where we get enough as a minimum for the pain relief, and I want them to push farther for additional benefits. And once we start taking 2 steps back, because now they're getting to the point where they're able to exercise enough that they're not getting or they're having that diminishing return for pain. Maybe there's some other things that are solved along the way, like maybe we help them lose weight, maybe we added more muscle mass, maybe we're building additional better muscle or bone tissue. Like there's a lot of things in a complicated scenario that this is only talking about osteoarthritis, but the human person with all the conditions and things happening as we age is so complex that I think we can expand that talk with the patient in front of us to include that, and then really manage like, yeah, we'll get the pain down at first. Hey, take a couple of months, do the minimum minutes. Hey, is your pain down? Yep, good. Now let's push further into getting more benefits with more movement up to the minimum recommended guidelines of the task. I can feel myself rambling on this one, and I'm kind of going off on maybe not tangents, but I feel like if I was listening to this, I'm starting to lose the plot, so I want to dial it back. Summary, TLDR, if you kind of did a blank stare near the end there, you need a minimum effective dose to get out of pain. We can get you there. We always want to shoot for more. We want to push to the point where there's diminishing returns, but there's going to be additional benefits that we're going to get along the way. So we can treat these patients with one of the things that they don't necessarily think they want or should be doing because this isn't comfortable to do when you have osteoarthritis. So we need to get these people exercising for lots of reasons. All right, I promise I won't go off on too many tangents with these last 3. First up, effective gaze direction recognition task on pain, range of motion, and functional activities in cervicogenic headache patients. There's 2 things that I want to talk about with this study. The first is gaze direction recognition on why that might help cervicogenic headaches as far as My understanding of it is. But then the second is when you're reading research, what they mean when they say certain terms, and hopefully highlighting that for some people when they just look at the abstract of a study and go, oh, they did physical therapy, or they did chiropractic, or they did this, and you think you know what that means, and I promise you, you know. So first up, gaze direction recognition task on pain. What is that? Well, it can be several things, but in this study, it was really just having the patient sit down, and you would train gaze direction. So you'd be sitting still, trying to be in a great posture, and you'd have a researcher cueing you either with your eyes or your neck or both to look at a different object in front of you within your field of vision. So let's say you had like 8 blocks with different numbers or letters on them. You'd be able to see them all in front of you, even if you didn't focus on any single one of them. And the researcher would then say, like 1, 7, 3, 8, and then he'd give you different cues. Eyes 1, eyes 7, neck 3. So you'd actually have to think about what you'd want to do, what you'd want to look at, how you'd want to look at. And during the initial phases, they would actually kind of do a Simon Says, like the researcher would be in front of them, demonstrating the task, and then the researchee, so the person having the actual cervicogenic headache, would have to first guess what the researcher was looking at, and then repeat and do the task themselves. And then they just kind of made it harder and harder by removing cues, removing visualizations, and leaving the patient kind of on their own with just verbal cues, and again, less and less verbal cues over time. So why did they do something like that? Well, because you have reflexes tied to your tiny neck muscles at the base of your skull with your eyes. They're called suboccipital muscular reflexes with gaze. So it's going to be, let's just do this. Find the bony part on the base of your skull and the back of your head, then go like 1 finger width below that on either side. You should feel some tight, not tight, you should feel some muscles on either side near the base of your skull. If you close your eyes and then you just look different directions, like left, up, down, right, left, it'll be very subtle, but if you focus in there enough, you should feel just a little bit of activity in those suboccipital muscles. What's happening is during the complex process of your body figuring out where it's at in space, combined with the fact that your brain is a great pattern recognition device, your body is really trying to set itself up for success with whatever it sees in front of it. And if that sounds a little vague, let me break it down a little bit. So in order to balance, in order to figure out where you're at in space, you have to get input or signals from your inner ear. There's like a little buoy inside the inner ear that helps figure out where you're at in space, whether you're standing still or moving. The displaced fluid in there when you walk, when you turn your head, helps one of the 3 prime inputs, or it is one of the 3 prime inputs that kind of tells you where you're at. The other one is your gaze, your eyesight. So it's telling you if I'm perfectly standing up straight in a good posture, my eyes are parallel to the horizon, I know where I'm at. If I tilt my head really far to the right, like I bring my right ear to my right shoulder, my eyes are telling my brain, hey, you're off to one side. My inner ear buoys shift, corroborating that fact. And then my neck musculature is holding my neck in this position. So the muscles that are relaxed are sending a certain signal to the brain. And then the muscles that are pulling to hold my neck in place are sending a signal to the brain. So all 3 of those things are telling my brain where I'm at in space so it can make a decision about what is the next best thing to do based on my environment. If I just want to stay still, great, nothing new, nothing crazy. If I'm in a weird position and something's coming at me, my brain goes, okay, based on my position, what do I have to do next? What muscles do I have to fire? What steps do I have to take to avoid this danger or go after whatever it is I see? So these mechanisms are in place. And one thing that happens is when you move your eyes, your brain's kind of anticipating, all right, if I look left, I'm going to use some of these tiny muscles to prep and hold my head in place because all I want to do is move my eyes. So I'm going to proactively use some of these. I'm, I'm going to use some of these small muscles to prep my head in anticipation for subsequent movement. Um, so it's like if I look left, it's kind of like my body wants my head to also turn left, but right now I'm only using my eyes. So there's a little signal that's sent to the base of the skull musculature saying, hey, hands on deck, we might move to the left here. So what happens is when you deal with cervicogenic headaches, these patients, there's some issue in the actual cervical spine that with all of this complex signaling going on to help figure out where you're at, the joints, muscles, etc., are sending a signal to the brain that it can't really interpret very well. And so it will then start having a headache. It doesn't like figuring out this problem if it's not getting good information from all three sources. So it's getting 2 out of the 3. The third one, it's just replacing some of that signal with pain because it doesn't know what's going on. To get ahead of cervicogenic pain, they will incorporate these eye movements because now you're not actively moving the neck, which a lot of people have issue with. If you have a cervicogenic headache, one of the things that you'll find is there's a lack of range of motion in a given direction because things are kind of putting on the brakes, like the neck and the brain aren't communicating well and they're having a bit of an argument. So one thing that you can do is utilize this eye reflex, as your eyes typically will help prep the movement of the base of the skull muscles. So you're using this gaze training where you're looking left and then you're actually moving your neck a little bit, and it's helping reestablish a good communication pattern between your brain and your neck via your eyes. So that's really what they're doing, and it did show good efficacy. Like both treatments showed good efficacy. They just said that adding gaze recognition task stuff enhanced that. So it's something that we can incorporate in patients that have this condition, and it's usually recurrent and chronic. But the second thing that I wanted to show you here, if I actually go down into this study, and employed a trial with 40 participants, yada, yada, yada. Here we go. The control group only received conventional physical therapy interventions. Well, what does that mean? Don't just assume, oh, physical therapy interventions. So they got, just a bunch of exercises. Watch this when I go down there. While the experimental group underwent both the aforementioned training and standard physical therapy. So that's the thing that's also confusing. In the first sentence, control had physical therapy interventions. Second one had standard physical therapy. Let's go down to, here we go, interventions, control group. So remember, these patients had an hour, I believe it, hold on, let me go back up. I'm sorry about this. I believe it was 3 hours a week. Yeah, here. 24 visits at an hour-long sessions over 8 weeks. So 3 times a week, an hour each time. They were going through what I'm about to show you. Here we go. Participants in the control group received selected physical therapy rehabilitation. Each session of the selected physical therapy program began with the application of a hot pack to the neck and shoulder region for 20 minutes. So a third of your appointment time is just having somebody place a hot pack on you. Okay. Followed by 20 minutes of a TENS unit. So they just talk about using standard settings applied to the neck area. So first 20 minutes, hot pack. Second 20 minutes is TENS units. So 40 of the 60 minutes is just you sitting there either with a hot pack on your neck or a little stim machine just kind of buzzing along. Okay. After that, they had ultrasound therapy was administered for 5 minutes to the affected neck muscles. Look, ultrasound has terrible, terrible results in the evidence. Like there's been several studies that outside of niche devices for niche conditions, it didn't do anything for a majority of what it's been studied for. So this is therapeutic ultrasound. Sound in and of itself can be a therapeutic tool. So this is where it can get confusing because we have shockwave devices that will use acoustic waves sometimes. There's different types of interventions that will utilize sound waves because it's a physical force. But when we're talking about ultrasound, it's a very, mm, it's almost no better in many applications than just putting a hot pack on, because that's really what it does to the tissues. If it does anything, it just heats up the tissue a little bit. So let's kind of recap so far. The control group had 20 minutes hot pack, 20 minutes TENS, and about 5 minutes of ultrasound, and they show you the intensity. And then, in addition to these modalities, which is a majority of the appointment, where these patients received 3 times a week for 8 weeks, was mostly hot packs and TENS units. Can you tell I'm a little aggravated by this? That this is quote unquote standard of care. Like, I know it says physical therapy, but this overlaps with chiro. This overlaps with a lot of things. I am livid that a lot of things are considered, like, this is considered a standard of care. Anyway, in addition to the aforementioned modalities, participants performed therapeutic exercising targeting range of motion, postural correction, and isometric strengthening of the neck muscles. So of all of them, since you're in the experimental group, you're basically doing this anyway. You can kind of can that in the control group, or just presume that part of the reason they got better is there's an overlap here. But the big things are they actually took their neck through a range of motion again, and they actually tried strengthening it again. These exercises were prescribed as 10 reps per set to be completed 3 times daily. So 30 sets, based on my interpretation of how they worded that, a day. If you're doing true, genuine isometric strength training, depending on how long you hold it for, that could either be too little or too much. As far as how fast you're moving the neck, was that left and right? Was that left, right, up, down? Was left and right 1 rep? Was left 1? Was right 2? Again, I think this is, I think this is, while it may answer some questions from a research perspective, this is thoroughly inadequate to be considered great care across the entire population for people who suffer cervicogenic headaches for a multitude of reasons. But I won't get into that at this point in time. All right, one more thing that grinds my gears. This comprehensive program was designed to address pain, improve mobility, and enhance function in individuals with cervicogenic headaches. Comprehensive program. Comprehensive program. Hot pack, TENS unit, ultrasound, basic range of motion, and an isometric hold. That is not comprehensive. Like, don't even say that word. That is, no, I am irritated on how they phrase this. Anywho, the experimental group added in this gaze direction recognition protocol with an additional 10-minute session within each hour. So when they said 60 to 70 minutes, control group 60, experimental group 70, because they had 10 extra minutes where they did that little gaze pattern thing. It was enough to have an added effect. It's cool that we can consider that reflex to help reestablish a communication network between the head and the neck and the brain. But when it comes to some of the verbiage and what they consider to be comprehensive care, as well as typical standard physical therapy, I wanted to highlight that for you. So when you see any big study or big highlight or big news article that pulls the abstract saying, take a look, this means that, it's just like, that, no, that is still so vague. You have no idea what happened. Like, one more example before I move on to the next 2 studies and wrap this thing up before it gets to be too long. A lot of times you'd see a study that says manipulation equals either good thing or bad thing. And a lot of times in those studies, it is presumed based upon stereotypes, and not unwarranted stereotypes, mind you. I will acknowledge that. But any study dealing with manipulation, it was automatically done in the study by a chiropractor. If you actually read a bunch of them, it could have been osteopathic manipulation, which a lot of times they will actually differentiate, but not always. Sometimes it's physiotherapists, sometimes it's chiropractors, sometimes it's uh, physical therapists. There are a ton of providers that can actually do manipulation. And what I don't appreciate is the presumption that if manipulation, depending on the study, is either good or bad, it's a reflection on the entire chiropractic profession as a whole, rather than, hey, look at this subgroup demographic that they were asking this question about manipulation with, as well as how they approach the manipulation, and ask yourself if that is standard of care for the provider that you see. Because I've seen some setups where, again, based on the abstract, you're like, oh, cool, interesting. Then you read how they did the adjustments or how they sub-selected which patient got what. And it's just like, how would this ever happen in the real world? And how would this be a conclusion that we can take across an entire profession or professions or entire intervention group or intervention modality? It's kind of silly when you read some of these that I have. Um, and then looking at this study, I have a lot of physical therapists that I know that I thoroughly respect that would come to the same conclusion I did under this study. Like, that is egregiously poor standard of care, even for this subpopulation, because of how much time is spent on passive modalities that we could almost flip as far as what the patient gets. Like, do you really need to go into a provider for an hour to have them put a hot pack on you in TENS unit, which are over-the-counter things that you can do at home at your own discretion and pay somebody for? No, you don't need to come in and overpay for somebody just to watch you and put a device on your neck. You don't need that. And then flipping it where it's like, oh, just do these things at home. Like, those are the things that are going to get you better. Why don't we spend the time making sure you're doing them well and that they're dosed appropriately for you, so that when you do them outside of the office, they're going to be effective? Anyway, I'm starting to get angry. Let's move on to the last two studies and wrap this up. Effectiveness of MSK manipulations in patients with neck pain, a systematic review, and network meta-analysis. This one, I'll just read the results and conclusions because I kind of went on a little bit of a tirade on the last one. So this one had a bunch of RCTs that they looked at. So 101 RCTs involving almost 8,000 participants were included. Several of the studies had a high risk of bias. Some had concerns and others had low risk of bias. What did they really get to the conclusion of? Well, multimodal treatment. Oh, look, yet again. So the combined use of 2 or more MSK manipulations or interventions is the most effective for reducing neck pain intensity and neck disability. Within this biased review, manipulation is the most effective for improving range of motion. There are others that I've seen where dry needling is the most for range of motion and manipulation is the best for pain. It really comes down to how they ask the question, what databases did they use, and which studies did they rule in or rule out. But this is just another one that highlights multimodal treatment. So doing multiple things to the patient, for the patient, and matching what they need to their expectations, their condition, and the provider's expertise is going to be the best thing for them. And you should, again, I will beat the dead horse on this over and over, find a provider who isn't myopic in their treatment approach. You're not a cookie cutter in their office, and they have a lot of different ways to approach you, your condition, that matches your expectations and their expertise to get you the best care possible moving forward. Last study, gender-specific biomechanical effects of smartphone use with backpack load during standing and walking. I'm not so concerned about the gender-specific biomechanical effects. I just wanted to highlight this one because there's a little bit of a fight and argument on social media between text neck. You've got some people saying, yes, it's the worst thing in the world, yada, yada, yada. You got others that are saying, oh my gosh, no, it doesn't do anything. It's just like posture. As long as you're moving, sustained, cervical flexion, looking at your phone, we're adapting to it. So it actually isn't correlated with pain. Again, I think there's somewhere in the middle. It's just like the dose response for the exercise. You have the people that adapt to that middle bit where it's not too much, not too little. Your body's just fine. If you do too much of it, I think you're going to have issues. But I think what they looked at in this one, we're adding backpack load. So you're adding a counter strain is going to exacerbate somebody actually developing neck pain when they use their smartphone. So I think that is something that I just wanted to highlight. So if we think about it this way, there's been on the one end, for the people that think text neck is the worst thing in the world, they focus on this bowling ball analogy that your head is exponentially heavier the farther you look forward. And then the people that, again, are on the anti-text neck thing where you're adapting to it, saying, hey, look, we're strong, we're robust, we can actually have these muscles adapt, and we actually aren't going to send the pain signal if we do it enough. But I think in today's culture, where we are also typically sedentary on average, we walk short bursts, we will often, for the people that are going to develop text neck, it's your what? Teens, young adults, is going to be the time when you develop it. Certainly adults suffer from this too, but as far as when or the population that first starts to develop this issue, it's going to be your student population. And I think the combination, or at least what they were getting at, the combination of adding that backpack, which is going to be pulling down with excess weight, combined with you trying to focus on this thing, you're going to create unnecessary counter strain in short bursts that are going to develop what people are talking about nowadays as far as text neck. So again, I'm that milquetoast, middle of the road fence sitter, where I'm not going to say it's one or the other. As an absolutist, I'm going to be in the middle where it's like, yeah, okay, I admit we can adapt to it. We're robust. We can actually handle that, yada, yada, yada. But I do think there is something to it that we should consider. And this might be one thing, is the combination of lifestyle factors, our general metabolic health, our physicality, us being prone to being sedentary, combined with our ergonomic strategies of overloading our backpacks while trying to look down at a phone, is not a strategy for success to avoid having excess pain and strain through our neck and upper back region. They came up with some ergonomic recommendations, such as, well, you've probably heard this before, but not overloading your backpack depending upon your gender between 10 and 20% of your body weight, and then limiting how much you're actually looking down at your phone. There's other reasons that I would just generally avoid this behavior. One is safety, if not pain. I'm a firm believer in being aware of your surroundings at all times. So, walking in a public area with your face down, buried in your phone, even if we're not talking about pain, I don't think is a good thing just from a safety perspective, whether it's your safety because of other people around you or the safety of other passerbys, where, people are walking, biking, driving. A lot of bad things can happen based on our obsessive compulsive need to do this activity. But that's just my 2 cents. I've let this thing go on longer than I wanted it to. Thank you for listening to my little tirade and rant there. Until next week.